This program is brought to you by Emory University.
Good morning, everyone. It's a privilege for me to introduce our speakers today. I'll start off by introducing Dr. Mark Westwood, who's a friend I've known for a number of years. He's a consultant cardiologist or attending physician at St. Bartholomew's Hospital in London, also known as Barts. Just a fun fact that Barts is now 902 years old. So it's the oldest hospital that's been functioning in the UK and probably around the world. So he's a consultant there. But apart from being a cardiologist, he's also a director of medical education there and professor of William Harvey Research Institute at Queen Mary's. He trained in Oxford and then did his medical education in London University and obtained his MD from there. And apart from being a specialist in imaging within cardiology, he wears lots of other hats and has a very illustrious career. He is now president of the Specialty Advisory Committee on Cardiology, which is a national training body in the UK, vice president of the British Cardiovascular Society, and president of the British Society of Cardiovascular Magnetic Resonance Imaging. He also has appointments in European cardiology as president of the Council of European Specialists of Medical Assessments, and has also participated as a member of the ACC Educational Committee, Competence Management Committee, as one of the few foreign representatives there. He'll be assisted by two trainees at Barts. First of all, Dr. David Thornton, who is a senior fellow in multimodality cardiac imaging. He's doing a fellowship in CMR and cardiac CT and advanced echo at Barts Clinical Lecturer at University of College London, where he also obtained a PhD funded by the British Heart Foundation on MRI imaging for myocardial fibrosis. And also Dr. Chadalavada, who is a final year cardiology trainee there as well. Her focus is heart failure and advanced cardiovascular imaging, also obtained a PhD in cardiovascular imaging. So it's a real privilege to have them Zoom in from London. And thank you very much. Dr. Westwood.
Thank you, Arshid. And I think we're just going to, George has got the presentation up. Thank you, George. Thank you for that very generous introduction. So welcome. So what we've done here is there's the three of us, and I'll do a tiny bit of introduction, and then I think, as is common, certainly in the UK, I will get the fellows to do most of the heavy lifting in this presentation. And we've got two cases, and really we want to stress the role, I think, of multimodality imaging in both of them. So they've both got multiple different imaging modalities. In fact, I think between us we've covered all four. There's definitely echo, CT, MR, and I think there's a PET scan in there as well. So what we wanted to do was think about how can we use multimodality imaging to get an accurate assessment of pathology, and how can that help us in a diagnosis and management, and really I think as well, as is increasingly common, just what is the central role of the multi-professional team, and how does this all kind of knit together. We get increasing amounts of information from various sources with our more complex cardiovascular patients and cardiovascular pathologies, and really just trying to think how we put all of that together to reach the most accurate diagnosis, and from that go on to the most accurate management and treatment. So I've managed to get two of our very senior registrars. They're both about to be attendings within a year. So I think I've said enough about the background and introduction. So I think with that, we should probably go over to Suchi, who's going to lead us through the first case. Thanks, Suchi.
Thank you very much for that, Mark. My name is Suchi. I'm one of the cardiology registrars at the Barts Heart Centre, and I've got an interesting case to present to you today. So the case revolves around, next slide, please, George, a 27-year-old gentleman who has a very rare genetic splice mutation. And I must say that this mutation even had Google stumped in terms of exactly what it entails. But the main feature is that it causes renal scarring leading to end-stage renal failure, which is why this patient had a renal transplant in 2019. It also has cardiac involvement, which in this case, this patient had as well, causing some complex left ventricular outflow tract obstruction, leading to surgery in 2007, along with a myectomy and resection of the fibrosis. And then further to that, he also had mechanical AVR and mitral valve replaced in 2018. He's on appropriate medications for these conditions. And although he was asymptomatic, on follow-up echocardiograms, they picked up increasing gradient through the mitral valve. And so they wanted to investigate this further by, first of all, doing a transesophageal echo. The TOE was done by a very experienced operator. Next slide, please, George. Who managed to acquire some nice 3D images as well of the mitral valve. However, as you can see, it's quite difficult because the posterior mitral valve leaflet kind of goes out of plane in the 3D imaging. And in the 2D imaging, it's quite difficult to see if it's actually even opening or closing normally. In other views, they also saw some fibrinous material, which they thought might have been thrombus. And they thought that maybe the posterior mitral valve was fixed and not moving. They also detected high gradient through the valve in the context of tachycardia during the TOE, as well as some mild to moderate MR. So really, based on this TOE, they were not 100% sure exactly what was happening to the posterior mitral valve leaflet in particular, and they didn't understand what the fibrinous material was, whether there was a thrombus or possibly pannus that might have been obstructing the valve. So on that basis, they requested a cardiac CT, which we performed. We did a retrospective scan, as you can see, with an element of dose modulation to try and limit the radiation, but because it was a retrospective scan, the patient had a relatively high dose of radiation received. I did give the patient some metoprolol, even though we were not necessarily focusing on the coronaries, because his starting heart rate when he came into the scanner was about 90 beats per minute. And we felt that this might impact the image quality as it did with the TOE, for example. So then the CT was actually very helpful. As you'll see in the next slide, the first thing that was apparent with the CT that you couldn't see as well with the TOE is that there's a lot of dense calcification around the mitral valve, particularly focused around the posterior aspect. And this was probably part of the fibrinous material that was being seen on the TOE, but it was very difficult to assess that because of all the metal artifact from the metallic valves when they were doing the TOE. So that was the first thing that was helpful from the CT. And because we did a retrospective scan, in the next slide, you'll see that we were able to put together some cines to demonstrate that the valve, in fact, was opening and closing normally. Again, this was only possible because we did a retrospective scan. So the payoff for the extra radiation that the patient received is that we were able to answer the question at hand, and there was no thrombus or pannus that was evident in the CT scan. So the patient was then discussed in the MDT with the CT available, and it helped in guiding the management in that at least it reassured that the valve does seem to be operating normally. They did increase the warfarin range in order to avoid any possibility of thrombus, because dealing with that might have been quite challenging in this patient who's already had 2 stenotomies. And he's under regular follow-up with serial echocardiograms. There is one more bonus interesting case point to this case, which you'll see in the next slide. It's probably easy to see in the second image below. where there is some asymmetrical, what look like pulmonary edema. And we hypothesize that, yeah, George is pointing that out for me. Thank you, George. So we hypothesize that this might have been a result of turbulent blood flow around that posterior mitral valve, which is then transmitting to this common pulmonary vein, and as a result, causing some congestion behind, isolated congestion just in that segment of the lung. This is quite subtle, and it wouldn't have been picked up if it wasn't for the CT. And it's also quite rare to have this. And if you just click on, like George, we've got some references that demonstrate there's only a very few case reports in the literature going back more than 20 years that have demonstrated something similar. We haven't been able to prove this in this patient because we would need another TOE to assess the pulmonary vein flow and demonstrate that there are higher pressures in that common pulmonary vein that you see there. And it's obviously not easy to detect at all on transthoracic imaging. But that's the theory behind what we're seeing in these images here. So to conclude then, yes, I have some guidelines here that promote the use of cardiac CT as an adjunct to echocardiogram, especially when you've got prosthetic valves and there might be acoustic shadowing and so on that make assessment of the valve quite difficult. Obviously, radiation is a concern, but in the future, we've got photon counting scanners coming online. We have one now at Barts, which can limit this quite significantly. And this case demonstrates quite nicely the use of CT for assessing prosthetic valves. Okay, and I just wanted to, yeah, as I said, the cardiac CT can be very useful in assessing these kind of valves, especially with when echocardiogram may not give you the result. So I just want to thank Dr. Amir Awad, who's the consultant radiologist who reported this case with me, and Dr. Bijal Pandya, who's the adult congenital heart disease specialist taking care of this patient, and the CT radiographers at Barts, who are amazing. And I think it's now over to you, George.
Yep, thank you very much, everyone, for having us here today. I think there'll be an opportunity, we'll hand back to Mark at the end, and there'll be an opportunity to ask questions about both cases. So if you've got any questions, just hold on to those for now. So the second case, this is a 25-year-old lady, originally from Cyprus. She presented to her local hospital with an episode of collapse and loss of consciousness. And this was preceded by feeling dizzy and having some intermittent palpitations. And when she originally came into the ambulance, her ECG showed atrial tachycardia, which then spontaneously cardioverted. When they were taking the history, she reported that she had been feeling generally mildly a bit more short of breath over the preceding months and was also feeling quite fatigued. She had no other medical history. She was fit and well. She wasn't on any regular medication. And importantly, in her family, there was no relevant past history of any cardiac disease, no past history of syncope or collapse, or any history of sudden cardiac death. Apart from previously being a smoker, she was a fully independent, working person, and didn't take any recreational drugs, and doesn't drink alcohol. So this was her ECG in her local hospital, and I'm sure you can all see that this is grossly abnormal. You can see that particularly in leads V1 to V4, there is deep T-wave inversion. There is also some T-wave inversion in leads 1 and lead AVL, and the suggestion of some increased QRS amplitude as well in the anterior lead. So a very abnormal ECG, particularly in the septal leads. So she went on to have a transthoracic echocardiogram, and we'll go through the images sequentially. So at the top, you can see the parasternal long axis view, and then at the bottom, you've got 3 cuts through the short axis. And what's immediately apparent is you can see this area of very, very marked hypertrophy in the interventricular septum, especially in the mid to apical septum, and appears to be sparing the basal septum. When you look at the color Doppler on the top right, you can see that because this lesion is quite low down, there's no flow acceleration in the left ventricular outflow tract. You're not getting any systolic anterior motion of the mitral valve. And that's obviously important in the context of her presentation of syncope. Similarly, in the short axis, you can appreciate that there's this large area of thickening, which is thickening at the expense of the LV cavity, but without much evidence that there's any complete cavity obstruction. And just illustrating that again on the apical images, with the apical 4, 2, and 3 chamber images at the top, you can see this mid to lower septal mass, and then at the bottom left, some color, and you can see that there isn't really any clear major flow acceleration throughout the LV. So she went on to have a cardiac MRI, and these are the initial images that we took. So these are the steady state pre-procession cine images, and you've got on the left the long axis views of the heart, and on the right you've got the short axis views, and you can see that we have contoured the short axis views to allow us to measure the heart size, the volumes, the mass, and the function of the heart. And I think the first thing to note is that you can see this area of very localized thickening, which looks quite iso-intense to the other myocardium in the remote areas to the area. When you measure the size and function, you can see that the cavity, and you can see the numbers all down here on the graphs. You can see the LV cavity is 120 mils. The LV mass is actually greater than the LV cavity size, and the LV function is high, it's 71%. This is using trabeculated contours, which always gives you a slightly higher ejection fraction than rounded. And you've got also normal RV function as well. There's a suggestion of slightly reduced global longitudinal strain, minus 14%. And when we measure this, the maximum wall thickness that we were able to measure in this area of thickening was 33 millimeters. So this is really extreme hypertrophy, if that indeed is what it is. So these are the pre-contrast tissue characterization images, and we've got on the left, we've got the long and short axis T2 stir images, and these are good for looking for areas of edema or fluid, and it's very subtle, but I think you might be able to be persuaded that in the area of the mass in the 4-chamber view, there is slight hyperintensity compared to the remote myocardium. On the T1 mapping, and importantly, this is at 3 Tesla. In our hospital, 3 Tesla, upper limit of normal T1 mapping is about 1300 milliseconds. In this mass, it's very high. It's 1475 compared to 1200 in the remote myocardium. So this can suggest fibrosis. It could also suggest increased water, which could be edema. It could be increased vascularity, for example. And similarly, on the T2 mapping, and this is again looking for fluid, you can see elevated T2 values, 58 milliseconds compared to 42 milliseconds on the remote myocardium. And note at 3 Tesla, these values are always a bit lower in general. Finally, we did fat water separation imaging. And the important thing to take from this is in the co-registered water area where you can see the hypertrophy, on the fat image, there's no enhancements at all. So that suggests that there's no fat in this lesion whatsoever. We then move on to doing first pass perfusion imaging. And so these are motion corrected perfusion images, 3 short axis slices. In our center, often when we're looking for unusual things like hypertrophic cardiomyopathy, we'll also take a single long axis slice. And what you can see is the gadolinium is entering from the venous access into the right ventricle, moving around the lung, into the left atrium, and then we see it enhancing in the left ventricle. And almost immediately, the area of the mass is enhancing, and it's enhancing more than even the remote myocardium. So what this suggests is that this is a highly vascular area. In hypertrophic cardiomyopathy, often this is associated with microvascular dysfunction, and particularly at stress. So this is rest imaging, but at stress in hypertrophic cardiomyopathy, you will actually see a perfusion defect rather than this area of hyperenhancement. Moving on, so early gadolinium enhancement, so taken straight after the perfusion, straight after we've administered the gadolinium, you can see that the area of thickening is enhancing, which again serves to provide evidence towards vascularity. And then on the late gadolinium enhancement images, so these are taken towards the end of the scan after a while after we've given contrast, you can see this diffuse heterogeneous uptake within the lesion, suggestive of fibrosis. Now, in HCM, you can get a similar appearance in areas of hypertrophy of this diffuse enhancement, but you would also be looking out for other areas of hypertrophy that can be typical in HOCM, such as prominent RV insertion fibrosis, but it's not always present. So just looking at the short axis view of the late gadolinium enhancement imaging, you can see those basal slices which are unthickened. There is not really any evidence of fibrosis. This area here, you might think is fibrosis, but this is quite a common place where you'll see a septal perforator artery lighting up, and actually it's often misconstrued as fibrosis. And then in these lower areas, you can see this diffuse heterogeneous late enhancement suggestive of scar. Because we're still really not sure what was going on here, the CMR was reported as possibly a mass, could still be hypertrophic cardiomyopathy. We threw everything at this lady and she underwent a PET scan. You can see this is the PET co-registered against a non-contrast CT. And you can see in the septum there's this area of quite significant uptake, which you can also appreciate in the 3D reconstruction on the right. So we still thought that this was quite atypical for HCM, but we really weren't sure what was going on. So we needed to move on, get some definitive histology. So the patient went for an endomyocardial biopsy. Now the report of this was fragments of myocardium and subendocardial thickening with mixed inflammatory cells, no inflammation, no hypertrophy, no interstitial fibrosis. And they were saying, we suggest that you correlate this with the clinical findings because we're not really sure you've actually biopsied the lesion. So this was a bit of a worry, and we needed to get an answer. So after much discussion, she proceeded to an open heart biopsy performed during cardiothoracic surgery, off pump, under direct vision. And this time we did find some results, and what we saw was myocytes, which were hypertrophic without inflammation, focally disrupted with surrounding fibrosis, and adjacent hypertrophied myocytes aligned obliquely. And the outcome of this was that these features were suggestive of hypertrophic cardiomyopathy. Now, by this point, we were all slightly panicking because we've just done a heart biopsy on someone who turns out just to have an inherited HCM. And we still felt that these imaging characteristics, although non-diagnostic of any particular condition, were not typical for HCM. And what we ended up doing was referring this lady's imaging and histopathology to a second tertiary cardiac centre in London. And when this was reviewed by their histopathologists, we got a different report. And this report stated hypertrophied myocytes with boxy nuclei, architectural disarray, blood vessels prominent, and fibrosis. And they reported this as a likely cardiac hamartoma. Indeed, their imaging was also reviewed, and they felt that the PET uptake was not consistent with HCM, and that the MRI findings would fit with a hamartoma diagnosis, or indeed possibly a hemangioma. So what is a hamartoma? So this particular hamartoma is a benign tumor of mature cardiac myocytes. typically presents histologically with haphazardly arranged hypertrophic cardiac myocytes with fibrosis and mature tissue, large hyperchromatic nuclei. And importantly, you look for the absence of HCM features such as crisscross myocytes and plexiform fibrosis. But these tumors can look incredibly similar to hypertrophic cardiomyopathy, so it's really difficult. They're sporadic, they're not associated with any genetic mutation. The cardiac MRI features are mainly described in case studies, but they tend to be hyper-intense on T2 weighted images with avid enhancement both on early and late gadolinium. Importantly, if you do a CT on these patients, they tend to have an absence of calcification. And this is important because there's another benign cardiac tumor that can resemble this, which is a fibroma, which often tends to be calcified. And so these are incredibly rare and they're limited. There's limited literature on this. So really, there's no imaging modality that is truly diagnostic. So you have to get all the information you can, and the diagnosis is histological. And even then, sometimes it requires second opinion. So very briefly, I'm just going to talk about cardiac tumors, and in particular, those that can be common hypertrophic cardiomyopathy tumoral phenocopies, meaning that they mimic hypertrophic cardiomyopathy. And these are generally divided into benign congenital lesions, benign acquired lesions, such as myxoma, hemangioma, and more malignant tumors. Now, I'm just going to focus mainly on these benign congenital ones, because I think these are generally the most similar to a cardiac hamartoma. So the first one is a rhabdomyoma. These are often, if you see them, they're commonest in the ventricle. They actually tend to occur primarily in children. They're characterized histologically by these spider cells, large vacuolated myocytes. Our second opinion histology report actually commented on their absence, making it more likely to be a hamartoma. And on CMR, they can show similar characteristics to a hamartoma pre-contrast, but with minimal contrast enhancement on late gadolinium enhancement imaging. And the index of suspicion for these particular tumor types is strongly linked to whether the patient has underlying tuberous sclerosis. So these are typical tumors to come up in patients with tuberous sclerosis. The other type, apart from a hamartoma that we've already been through, is a cardiac fibroma. Again, if they're in the heart, they tend to be in the ventricle, but their histology is different. So they have tumor cells that resemble fibroblasts, and you'll often get calcification alongside, which you might see on a CT. The CMR images, again, you get this heterogeneous late contrast enhancement, but importantly, the enhancement tends to be more around the outside of the tumor, and you might get this central core of hyper-enhancing areas. So this was a really difficult case. I thought it would be a good one to think about. The take-home messages from this case were that multimodality imaging can be really, really useful in the diagnosis and characterization of cardiac masses. But in truth, for most cardiac masses, histology remains king and is essential for definitive diagnosis. Cardiac hamartomas of mature cardiac myocytes are rare, benign tumors and may mimic hypertrophic cardiomyopathy. And they often appear iso-intense to normal myocardium on MRI, which makes it really difficult. And finally, when things don't quite fit together, it's really important to get multidisciplinary review, second opinions, so that we can prevent misdiagnosis and optimize the treatment of these unusual cases. So that's it from me. I will pass back to Mark and we'll take any questions there maybe.
Thanks very much, George. So thanks both. So I hope that's been interesting and useful to everybody. We've tried to show across two really quite different pathologies. One, obviously, a valvular lesion that we did use echocardiography, of course we did, but the added value of the CT scan. So again, going through multimodality imaging, and then really a slightly complicated case. In fact, I remember the MRI case because there's one bit of the history that George doesn't know, and that there was another MRI scan actually before the one that was performed, which was performed actually in Turkey, where the patient's from, where we actually couldn't quite make head or tail of what they'd actually done, and was really challenging. But I think with that second case, all of us were sort of thinking, well, we kind of in some ways want to say this is hokum. You know, we look at the cine imaging, it looks so intense, that area of hypertrophy compared to the rest of the left ventricle, but somehow just how that shape, that sort of rounded globular shape, is really quite atypical. And also the location being sort of 2/3 of the way down the left ventricle was really just a little bit too concerning for us. And we thought, this is quite unusual. You can get obviously localized areas of hypertrophy and hypertrophic cardiomyopathy, and particularly towards the apex with apical, but it doesn't tend to look like that, and it doesn't tend to be quite so localized just on the septum. So that's why we kept pushing and pushing. And also, of course, the PET scan didn't, you know, the PET scan plus the perfusion didn't really add up. So I hope that's been really useful. I apologize, we seem to have been ahead of ourselves in terms of schedule, so it is a bit shorter than we were asked. But on the other hand, I hope that gives us lots of opportunity for questions, which I'm happy to take. Just at that point, I can see one's come up in the chat already from Shannon, which says, any recommendations for differentiating severe hypertension versus HOCM with a multimodality approach? It's an absolutely fantastic and brilliant question. And what I would say, I mean, if I talk about the MR side of things, so there's two things. One, we used to say that any late gadolinium enhancement, so any focal fibrosis, would push you very strongly away from hypertension and would push you very strongly towards hypertrophic cardiomyopathy. That's the sort of very classical view. And one of the things that we now know is that if you look at quite severe hypertensives, particularly those who get sort of 17, 18, 19 millimeters of hypertrophy, they actually do get areas of scar and patchy fibrosis, particularly around the RV insertion point. So that's where the right ventricle inserts on short axis into the left ventricle at two points. Particularly that, we now really don't ascribe too much weight to that at all. So I think our multimodality approach is, one, a good history is really useful. So somebody who's known to be hypertensive, poor compliance with medication, etc., that would be a really good start. Number two, we'd always want an echocardiogram, and then we'd probably do an MRI scan at least once on top to look for any patterns of focal fibrosis. The other thing that we know is if there's apical relative hypertrophy or apical hypertrophy, actually doing a perfusion scan is quite useful. There's some few now increasingly towards the left ventricular apex. In apical hypertrophic cardiomyopathy, you will get perfusion abnormalities which precede then the scarring that will come later on, and that might be part of the overall cascade. So we actually tend to perfuse a lot of our particularly query apical hypertrophic cardiomyopathies, particularly to answer this question. If you're still sitting on the borderline in that sort of 15 or so millimeters hypertrophy, and there's really nothing to define it one way or the other, ECG not particularly abnormal, we'd probably try and do a period of really aggressive control of antihypertensive medications if there's any evidence of hypertension, and then come back and repeat the scan and we see anything. So anyway, that's answering that question extensively, but very happy for any more questions.
Thank you, Mark and George and Suchi. Very nice cases. Perhaps I can ask you a question. This the second case presented with syncope, right?
Yes.
So would you consider an ICD or something? I mean, why did she have syncope?
It's a really great question, isn't it? Because technically there's gross abnormality there. I know
we don't really know exactly what the mechanism of this syncope was, but what we did have was a prolonged admission of about 3 to 4 weeks whilst we got to the bottom of all of this, where she was continuously monitored and on telemetry, and we never saw a single episode, not a single ventricular ectopic, non-sustained VT, or anything of that nature. So on balance, the decision was made that in this sort of otherwise well, young, fit 25-year-old, subjecting her to an ICD without defined evidence of ventricular arrhythmia was felt to be overall excessive. I think the difficulty with hamartoma is that they can present as completely incidental, or they can present with sudden cardiac death, depending on the location and what structures they are impinging upon. I don't think there's any, they're so rare that there isn't really any available literature to guide you in this situation. What ultimately happened to this patient, by the way, which I didn't mention, is that we've followed her up as an outpatient. The problem with resection of this tumor is that it was such a large tumor in the septal location, and so complete resection would have been impossible. We're following her up for symptoms and to see how she progresses, and it may be that eventually she needs a debulking procedure if she becomes more symptomatic. But we've opted overall to treat this conservatively. Whether that's right, I don't know. But that's what we did.
I have another question from Dr. Mehta here. For patients who are admitted with MINOCA, myocardial infarction with normal cardiology, are you automatically ordering CMR if angiography is not revealing?
Yeah, it's a great and classic question. Thanks very much. Yeah, we do, and that's actually part of our pathway here now. So obviously the patients will go to the cath lab and be treated appropriately. If we get minimal / no, if you like, no obstructive coronary artery disease, then we will generally try and get them in the MR scanner, usually as fast as we can, so within 48 hours. The reason for that is twofold. One, I mean, obviously we want a diagnosis, but two, particularly in terms of some of the changes with myocarditis, they're actually quite temporary. So if we don't do it as an inpatient and we wait and then bring them back when they're convalescent, even just 2 or 3 weeks later, your diagnostic performance of MRI, which isn't perfect anyway, is actually falling off, particularly around some of the edema imaging. So yeah, we like to get them in the scanner, and we like to do it quite early. So we would generally, quite often, they will have their emergency or sort of emergent cath, and then we'll put them in the MRI scanner the next day with contrast and basically assess them for myocarditis. So yeah, that's generally what we would do.
Other questions?
Mark, Steve Clements.
Hi.
Those were two very good, interesting cases. The first one, I like to say, after you get a gradient doesn't fit the situation, that fluoroscopy is like the next step to make sure the leaflets are moving. So CT showed that beautifully. And, a quick trip to the cath lab will also show you. The second case, if you ask about what one would expect the EKG to show after seeing that MRI, then I would say maybe it would show something like an anterior Q waves. It didn't show that. It showed anterior T waves. And looking at the EKG, you would think that's some form of hypertrophic cardiomyopathy. And maybe that's what you did. But the EKG is kind of a eye opener, and it would have led me astray in that one. I've been kind of interested in the tumor bloods that you get with tumors like myxomas show venous lakes and usually empty into the cardiac chamber, and hypertrophic areas show systolic squeezing of the vessels inside the hypertroph. And I guess we didn't do that, but you got a general idea from the MRI about the blood supply to that, right?
Yeah, I mean, it's when we're not doing sort of it's not dobutamine stress, so it's just adenosine stress, so it's like vasodilatory. But in hypertrophic, if it was hypertrophic cardiomyopathy, you either get nothing or you get hypoperfusion. This was just a rest perfusion, so you haven't made them hyperemic, so it's much harder to interpret. But if you sort of take, a sarcoma or something, so going right to the other extreme, what you
Right.
see is just, it's a very pleiotropic response. You see areas that don't perfuse at all, areas that hypoperfuse, because it's obviously that's extremely aggressive, and there's areas of necrosis and everything within it. I completely agree with you over that ECG. I think that ECG, if you showed that ECG and didn't say anything, I think 99 out of 100 cardiologists would write hokum. I think we'd all write it. I think, deep anterior T-wave inversion, if everything you've described, you really would, that would be, in a young person, it would be your number one diagnosis. And I think you're right, because of course that was the first test and it looked so classical, I think that might have colored some of our thinking. Your question about the first case and why not just a 2-minute trip to the cath lab would have done it. And when I saw this case, that was the one thing I thought about is we could have just gone to the cath lab. I guess we wouldn't have got the information about all the fibrotic strands and all the other bits. But in terms of is the valve moving,
So
I
Mark,
actually think
that was
go on.
discussed actually. They were considering whether to take to the cath lab. But as you said, they weren't sure if there was any pannus or thrombus, any microthrombi. So they felt that a CT would be better. The parent team felt that a CT would be better to look at all of those things in one go. And as you said, you wouldn't have maybe picked up the calcification. You also would not maybe have seen that subtle pulmonary congestion without the CT.
Correct. Those are two very interesting cases. Thank you.
Pleasure.
Good morning. This is Dan Vierel from Cardiology. These fibrinous stands in the first case in the mitral valve are not going anywhere. And I know the patient has many comorbidities, but this is going to be a progressive problem. Certainly in our institution, our surgeons have suggested replacing the valve, but this patient's had 2 stenotomies. And you already see constrained pulmonary edema in one lung, which is not going to go away anywhere anytime soon. So what are your long-term plans? Do you think this patient will end up with a third surgery?
I think it's quite possible, but for the moment, with the patient being asymptomatic and we have some reassurance that the valve is opening and closing normally for the time being, I think the close follow-up is probably the right way to go for the moment. But yes, with that degree of calcification, which might progress because of his underlying condition, it's quite possible that the patient might be heading towards a third stenotomy sometime in the future.
Yeah, I mean, I think ultimately we'd agree. We can see ultimately perhaps where this will head, but I think given their underlying condition, number one, and a third stenotomy, sort of going back in, these are always quite high risk, complicated procedures. So I think generally our view is we'll probably hold off as much as we dare, shall I say, I think would be the strategy with that we would probably follow at the moment. But I think at some point we probably will have to go in. Of course, you've got to temper that with if that sort of small area of very mild localized pulmonary edema, if that turned into florid pulmonary edema, that's not good either, because that would, if they've become highly symptomatic, that's going to put the potential morbidity and mortality associated with a third time surgery up significantly. But yeah, I think your points are very, very valid. This is going to be an ongoing observation and a nuanced decision.
Any other questions? I'm not hearing any more. This was fantastic, Mark and George and Suchi. Thank you for taking the time and educating us on multimodality imaging. Fantastic cases. We expect to host you later on in the week, Mark. Thank you very much, everyone.
Thanks very much, everyone. Thank you. Bye-bye now.
Thanks for having us. Bye.
Thank you very much.
The preceding program is copyrighted by Emory University.